Good evening and a very warm welcome to everyone. I am Neetu Abraham, Community Manager at Medisage e-learning. At Medisage, we empower doctors with the right blend of knowledge and technology to enhance clinical practice and patient outcomes. With AI transforming healthcare, we are excited to. Is there an echo? Is it from my end?
Yes.
Okay. Yeah. So, with AI transforming healthcare, we are excited to introduce Sage AI, a medical grade AI built exclusively for doctors. It is now available freely on Medisage app, offering reliable evidence based support anytime, anywhere. Now, let me share my screen first and introduce you to today's webinar. Hope my screen is visible.
Yes.
Yes.
Yeah. So now let me welcome you all to GOGS Abhyas Webinar series organized on the occasion of World Birth Defects Day. Today's session brings together leading experts to discuss one of the most critical responsibilities in obstetric practice, early identification and effective prenatal strategies to reduce the burden of congenital anomalies. To start with, introducing you to Dr. Shama Sultana, our moderator for today's session. Dr. Shama is a young, enthusiastic, and cheerful obstetrician and gynecologist, as well as an infertility consultant. She is the chairman and co-founder of Hopewin Hospital and also working as a gynec consultant at Star Hospital, Guntur. She did a PG diploma in assisted reproductive techniques from Kehl University, Germany, and training in basic ultrasound and endoscopy from Foxy. So with this, I welcome you, Shama ma'am, and over to you to carry the session forward.
Thank you. Thank you, Neetu. Good evening, everyone. On behalf of Guntur Obstetrics and Gynecological Society, GOGS, I warmly welcome you all to the GOGS Abhyas Webinar series organized on the occasion of World Birth Defects Day. So today we come together with a shared commitment to create awareness, strengthen prenatal care, and reduce the burden of congenital anomalies through early detection and timely intervention. And birth defects affect millions of families worldwide, but through knowledge, screening strategies, and collaborative medical efforts, we can bring hope, prevention, and better outcomes. This webinar from GOGS is a step forward, promoting early prenatal screening, enhancing diagnostic skills, and spreading awareness among healthcare professionals, and ultimately ensuring healthier generations. We are deeply honored to have with us eminent leaders and experts in the field of obstetrics, gynecology, and pediatrics who will enlighten us with their valuable insights. And let us learn, share, and work together towards a future where every child has the best possible start to life. Once again, welcome to the GOGS Abhyas webinar series, and thank you. And let me introduce our chief guest of today. Ma'am, chief guest of today is Dr. Madhuri Patel, ma'am. It's a true privilege and honor to introduce our esteemed chief guest for today. And on this webinar, on the occasion of World Birth Defects Day, and we are deeply honored to welcome ma'am. And she is the president-elect of Federation of Obstetrics and Gynecology of India, FOXY, and Dr. Madhuri Patel, ma'am, is she is distinguished in the field of obstetrics and gynecology, known for and advancing women's health care and across the country. Our commitment to academic excellence, maternal health, and preventive strategies has inspired countless practitioners nationwide. As a president-elect, Foxy, she continues to champion initiatives that strengthen clinical practice, promote evidence-based medicine, and improve maternal and neonatal outcomes. Her presence today is immense value to this webinar, especially as we address the critical issue of congenital malformations and prenatal screening strategies to reduce the burden of birth defects. Ma'am, your leadership and vision continue to guide us, towards safer motherhood and healthier generations. On behalf of Fox, it is our proud privilege to welcome you, ma'am. We look forward to your inspiring words and guidance. Over to you, ma'am, for your pearls of wisdom.
Thank you, Shama, for your kind and warm words. This is Dr. Venkateswara Rao, Dr. Rajkumari, who are the chairperson today. And I know Dr. Venkateswara since so many years, and he has really helped me a lot during my election phase. And I'm thankful to all and to the society for electing me as a president-elect Foxy 2027. With this, we have our speakers, Dr. Sushila, is a fetal medicine consultant, and is going to talk on condition information, a ray of hope. Our second speaker is Dr. Jyoti Prakash, who is a pediatric cardiologist, and he is going to talk on prenatal screening strategies for reducing the burden of birth defects. And of course, our moderators, young moderators, Dr. Shama and Dr. Anuradha, and all my dear friends, very good evening to all of you. We all are aware that 3rd March is the World Birth Defect, Day. Here, we are making aware not only community about, how to prevent or how to treat this condition, but also we are sensitizing our gynecologists and obstetricians for the same. If you look at it, the WHO has said that, WHO has given the figure that the 7% of the neonatal mortality occurs due to birth defects, and about 3.3 million babies, they die under the age of 5 because of the birth defect. And our India is no lesser. Our country is suffering, the prevalence is given at about 7%, which is definitely high for our country. So we are aware that this birth defect is always occurring during the organogenesis period. So first 3 months, that is 12 weeks, up to 12 weeks, it is very important. Here the role of preconception counseling occurs because now our girls are educated, the woman is educated, she's aware about it. So many of them come for the preconception counseling. So we have to motivate them not to have alcohol, not to take any drugs. At the same time, smoking is also she should not do it. Secondly, there are sometimes in the family history of trisomy. So we have to be very, very careful about this condition. So now we know the major birth defects are cardiovascular, CNS, and of course our what you call as Down syndrome. We have so many measures have happened, the advancement of the investigation, where we can have, apart from preconception counseling, pre-pregnancy, we have a dual marker with congenital malformation in 18 to 20 weeks, and of course, 22 to 24 weeks, we have echocardiography, where we can diagnose many of these birth defects, and if we want to come the genetic or Down syndrome, we can always go ahead with choriovenous sampling and amniocentesis. So with this, we are aware that we can definitely terminate the pregnancy nowadays, which has been extended to 24 weeks of gestation for this incompatible fetus. And for compatible fetus is a choice of, parents to decide whether they want to continue the pregnancy or not. But if they are coming beyond 24 weeks, we have no choice but to deliver them. Now let us look, I would like to give one example. When many years back, when I was resident, the diabetes screening was, not, universal. We never used to screen for diabetes. Now, since last 15, 20 years, we are having universal screening for the diabetes mellitus. And, one of my patients, she was infertile patient, she conceived, she delivered, and on the 3rd and 4th day, we diagnosed, after delivery, that she had a major congenital malformation. So we missed that condition, and it was because of the high sugar in first trimester. So we should be aware that hyperglycemia in first trimester is a major cause of congenital malformation of fetus, and therefore blood sugar should be also controlled during the preconception phase. Very, very important part. And one patient at 18 to 20 weeks of pregnancy, there was no congenital malformation. And at 7 months, that she came at 28 weeks, and it was diagnosed as congenital hypertonia. Of course, we delivered that baby, and baby underwent operation, but he could not survive. So there are certain conditions where nowadays we can diagnose. We have fetal medicine specialists who can definitely do the much more work than our obstetrician, and we can definitely have healthy babies or a good life to the babies where they are compatible with the birth defects. Which I would like to congratulate, Guntur Society for this web series Abhyas, which is held in every once a month. And I'm very happy that certain topics are very important for our OBGY community. And today we are going to learn a lot. With this, I would like to end my talk with quotes by Nelson Mandela. Education is the best weapon when used, it can change the world. So dear friends, update our knowledge, and we should know what we are doing so we can give justice to our patient and the babies, and we want future generation to be healthy not only for the family, community, as well as nation and entire world. So we should have future healthy babies or the adults or the population who can serve most nicely to the community, nation, and the world. With this, I thank you once again for inviting me as a chief guest and honoring me. And thank you once again for the same.
Thank you. Thank you so much, ma'am, for joining us. Thank you. So, with this blessings of Madhur Patel, ma'am, we shall go ahead. I want to introduce my co-moderator, Dr. Anuradha Manchikandi, ma'am. She is a maternal fetal medicine consultant at Aster Ramesh Hospitals, Guntur, and she's the secretary of Society of Fetal Medicine AB chapter. And she has a faculty in various national and state conferences and many other presentations she have done. We welcome you, ma'am. Please take over the session.
Thank you, Shama, for the introduction. Now, as Madhuri ma'am told, now World Birth Defects Day is celebrated on 3rd March every year. And most common anomalies are congenital anomalies are cardiac defects and neural tube defects and the chromosomal conditions. Now, with the advancement of fetal medicine and genomics and neonatal surgery, the has transformed outcomes dramatically over the last few years. What was once undetectable was now detectable, and what was once fatal is now treatable. So now from the experts, we will listen how which congenital anomalies can be managed by multidisciplinary care and we can give a good outcome. Now I invite our chairpersons, Dr. Venkat sir, HOD and President of Guntur Obstetric Gynec Society and the head of the Department of Katuri Medical College, and Rajkumari ma'am. She is a consultant at Ahalya IVF Center, and ma'am worked as a professor at Katuri Medical College, and madam has special interest in infertility and adolescent gynecology, and madam is a member of Parliament organizing secretary. I invite Venkat sir and Rajkumari ma'am. And our speakers today are Dr. Sushila ma'am and Jyoti Prakash sir. Rajkumari ma'am will introduce about Sushila ma'am.
Yeah, good evening, everyone. It's a privilege, madam, to have you as our chief guest. I will introduce Sushila, madam. Thank you.
Hello.
Hello, Anuradha.
Madam, your voice is not audible, Rajkumari madam.
Yeah. Yeah.
Ma'am, unmute. It's not audible.
Yeah. Good
Now
evening,
it's okay.
everyone. It's a privilege to have Madhuri Patil madam today with us. I'm honored to introduce Dr. Sushila. She's a renowned fetal medicine specialist and she is from Hyderabad. She has special expertise in managing high risk pregnancies, particularly twins and higher order multiple pregnancy. Madam is actively involved in academics and widely respected in her passion in teaching and training postgraduate students, fellowship trainees, and practicing obstetrician and gynecologists. Madam, you can start your talk, madam.
Thank you, madam, for the kind introduction. It's been a privilege to be a part of this academic event. Yeah. Thank you, organizers, for this opportunity. Always, Venkat sir is my teacher, and then, as a matter of fact, Dr. Anuradha is one of our fellows from the Fernandez Hospital. So, between two generations, I am kind of trying to mediate and then share the knowledge, whatever I can. Can I share my slides here?
Yes, ma'am.
Ma'am.
Am I audible
Yes, ma'am.
or my slides seen?
Yes.
Yes, ma'am, they are seen.
Thank you. So, it's not too long ago that we had this occasion where we wanted to actually we used to run to the labor wards and then see somebody birthed a baby like this. Perhaps it is in, 2000 and before that. So, is there a hope for these kind of underprivileged or the people with special needs when they are born? What is our role as the practitioner to help these couples? So, congenital malformations are structural or functional anomalies that occur during intrauterine life. There are many names for that. So one of them is birth defects and then structural abnormalities. What is important is it is not just the structural abnormalities, it is also the functional. As ma'am has said, globally, approximately there are 2,95,000 babies born and then, with these disabilities, and then they die before reaching the 4 weeks of age. Basically, there is social stigma and also lack of support, which can lead to this. I'm not able to move my slides. Hello?
Yeah, ma'am, what you can do it, you can press escape button. You will come back to your number of slides. Yeah.
Sure. So there are many classifications which are there, like major, minor, life limiting, and then severe morbidity, all those things. But for the sake of for this talk, I have divided or I have taken the classification as structural abnormalities, which are physical, and then functional, developmental, and metabolic. Over decades, we have seen that the technological improvements in the ultrasonography as well in the prenatal. And today, if you ask the accuracy or detection rate of first trimester abnormalities for the life-limiting conditions is as high as 93%. By and large, around 70 to 80% of major abnormalities can be identified for the first trimester scan. So whenever there is a congenital malformation identified, this is the pathway through which the couple will go through the diagnosis, workup, management. If it is life-limiting termination, and then if at all there is a treatment, we would do that in the prenatal or in the neonatal period. And also, depending upon the cause, we also will give the risk for the future pregnancies. So the prenatal ultrasound, as I have said, coming to the anencephaly, the example I quoted, which was a birth surprise, can be picked up at 11 weeks of gestation itself. It is a devastating condition to the parents and then, the practitioners as well. But it can be identified as early as 11 weeks, and then there is no hope for this. Not only that, various genetic abnormalities or even multiple abnormalities which include trisomy 13, 18, which lead to severe morbidity or even the early neonatal death also can be picked up on the first trimester when the ultrasonography will show us the lot of multiple malformations. But does it need that every malformation need to be terminated? This is what Dr. Anuradha asked me to talk about. Here is a one woman who is referred to us saying that she wants to undergo termination of pregnancy because there is something protruding from the mouth identified. And then not only the ultrasonography, we required another modality, that is the MRI, and then which showed most likely diagnosis of a benign tumor like ranula or lymphangioma, and hence she continued pregnancy and had meticulous follow-up subjected to the neonatal surgery, and then it showed like a benign mucinous epithelial cyst. So the modality it helped us is, apart from the ultrasonography, MRI here. Coming to the genetic workup, there are array of tests available these days, not like when we were postgraduates and fellowship students, it is only few tests. But how do we select this? Each abnormal scan has to go through a genetic counseling, which has pre-test counseling and post-test counseling, because so many unexpected findings may pop up in the genetic report. These are the important things. The microarray is the standard of the standard test these days, not the karyotype, because it can also give us 2 to 5% of additional information like pathogenic submicroscopic copy number variations, which may not be picked up by the karyotype. The diagnostic test remains the same. The amniocentesis standard after 16 weeks or in the first trimester, chorionic villus sampling, and we rarely resort to the fetal blood sampling these days. Here is a case where, a non-consanguineous marriage, second gravida, family history of intellectual disability, and the first pregnancy, she had termination of pregnancy for the agenesis of corpus callosum. And unfortunately, at 16 weeks, again, there was a suspicion, and then 20 weeks, it proved to be again a corpus callosal agenesis, and CMA was done normal. Because agenesis of corpus callosum, she underwent the termination of pregnancy and autopsy findings confirmed. So what is the answer that we give to this family? It is not just the CMA. In this case, there is a ping pong, that is a dialogue with the geneticist. And then because the DNA is stored, she asked further to analyze this DNA for the genome sequence, and then whole exome sequence. Whole exome sequence has identifies a pathogenic variant, which is the cause for this recurrent anomaly. And hence, in the next subsequent pregnancy, we can target the study of the prenatal sample, not just for the CMA, but for this particular gene which is identified. Therefore, doing exome sequence for all the patients or all the abnormal babies is not correct. We have to stagger them, and genotype phenotype matching is very important. Further moving forward, here is one case which was like identified as omphalocele in the first trimester itself, and then we know that counseling done, CMA is normal. She came for the serial scans, and then she continued the pregnancy because it is correctable, CMA is normal, and then we operated the baby after birth, and then outcome was wonderful. So in case of the genetic reports are normal, then women can continue the pregnancy and can have a normal outcome of the baby after the surgery is corrected. Here is another example, primary 20 weeks, referred for the diaphragmatic hernia, and then the scan showed isolated diaphragmatic hernia. Genetic testing is normal, and then on examination, lung head ratio or observed to expected lung head ratio is normal, and therefore they continued the pregnancy. Again, she has a normal birth followed by the operation of the surgery for the neonate, correction of the diaphragmatic hernia on day 2, and then baby is discharged on day 7. Is there anything that we can do in the prenatal period, but not just there in the neonatal period? There comes the role of fetal therapy, a therapeutic intervention for the purpose of correcting the anomaly. And then we have to remember, whenever we actually say that we are subjecting this offering the fetal therapy, in these cases, in almost every case the fetus is at risk of intrauterine death and then severe morbidity from the abnormality. Again, I have to escape. Slides are not moving.
Ma'am, either press the space bar button or the downward arrow key.
Okay. So the coming to the fetal therapy, there are many important things, but what plays an important role either by ultrasonography or fetoscopic guided procedures. Procedure counseling is extremely important because, as I have said, perhaps we would have lost these babies otherwise, and hence, still after the procedure, also there remains a high risk for this loss of either in the prenatal or in the soon after the neonatal therapy. So coming to the diaphragmatic hernia fetal therapy, it is aimed at improving the lung development in utero. It is a minimal invasive percutaneous procedure. It is the option for severe and then moderately severe cases. So this is the ISUVOG video which has given how the diaphragmatic hernia takes place, especially in the left-sided diaphragmatic hernia. This particular procedure is useful. As you understand, the feto aims at improving by introducing this balloon into the trachea where it is inflated so that tracheal occlusion happens, and because of this there is egress of the fluid and hence lung expansion occurs. The important thing here is that the cause of death in case of diaphragmatic hernia is that lung hypoplasia, and hence the lung hypoplasia is prevented by doing this feto procedure. So interestingly, ISWAG said that it is useful in suboptimal care where the neonatal care is there. Actually, this neonatal care is suboptimal. I am unsure whether this particular procedure is still available or not. In India, though Gratakos, one of the professors said that he had more than 2,000 cases done. In India, we have not done one yet in any of the centers, in tertiary care centers, because the tracheal balloon is at the moment not available. And second thing is, whenever the procedure is done by feto, and then that is fetal endoscopic tracheal occlusion, also at 34 weeks of gestation, we have to do another procedure and then burst the balloon so that then only the delivery of the baby can happen. So there two procedures are required. At the moment, the tracheal balloons are not available in India, but some centers are ready to do that in case of once we get this change in the balloon and then technique also. Another case is the 23 years primary, 19 weeks anomaly scan. As you understand, as was already mentioned, the neural tube defect is the commonest defect that we come across in India. And then most of the couples, they undergo termination of pregnancy. But the question that we need to ask ourselves is there any other suitable option available? So this is one of the cases that we identified during the antenatal period. Couple continued because there is a lipoma, and then this is the neurosurgeon who has done this lipomeningocele repair, and you can see here the baby has normal milestones and doing very well. So the cases, important thing is that we need to select the cases properly. So the advances in case of myelomeningocele surgery is that fetal open surgery, which includes hysterotomy and delivering this fetus halfway and then identifying the defect and closing it the way it is done in the postnatal period. But as you understand, the women here is subjected to the hysterotomy, which is like very severe condition, and then morbidity will increase. Therefore, there is further advance in it. Because of the mom's risks are there more in this case of open fetal surgery, there comes fetoscopic spina bifida repair. As you can see, whether you call it as laparotomy or cesarean section, laparotomy perhaps, because the gravid uterus is delivered through the wound and then the fetus is identified. You can see the identification of meningomyelocele, which again is, can be repaired. And as you understand, again, this fetus is reposited. It is already inside. The surgery is done only by the fetoscopic procedure. Therefore, there is no scar on the uterus, and hence these women can continue the pregnancy. And the literature says that even they can have a normal vaginal birth as well, and no risk of rupture in these cases. Coming to the other procedures that can be done is the thoracoamniocentric shunt. And then here in this case, you can see that either in pleural effusion or CPAM with a very large cyst, this thoracoamniotic shunt can be done, assembled. And important thing is that if we do repeated thoracocentesis, there can be reaccumulation, whereas if a shunt is left, this fluid will be drained into the amniotic fluid, and hence the baby lung expansion will happen, and then morbidity can be minimized. But important thing is that this shunt should never be in the anterior mid-axillary plane. It has to be in the posterior, because otherwise the fetus may pull the shunt through that. Another condition where the shunt procedure can be done is what is called as the megacystis, or enlarged bladder, which can be identified in the first trimester itself. The longitudinal length of the bladder more than 7 millimeters is called as the megacystis. And in these cases, once we exclude all other abnormalities, it can be a vesicoamniotic shunt, or even posterior urethral valve laser fulguration can also be happened. But extremely important thing is that we have to identify these cases properly, which need this. Severe enough to compromise the lung or renal function, or if it is not severe enough to cause the irreversible damage. In between these areas, we have to identify the optimum time and optimum case to do this. So vesicoamniotic shunt, the same way it is done as the thoracoamniotic shunt, it can be done, and you can see the shunt remaining here. But the challenges are more in cases of the vesicoamniotic shunt, because there is oligohydramnios, irreversible renal damage. The literature is not very comfortable, or giving not much information and good prognosis or outcome, because most of these babies still can have chronic renal failure. A word about the existing vesicoamniotic shunts. It may be a Rodek shunt, or it may be Harrison shunt, but all these things are important, because there can be a replacement or the loss of this shunt into the amniotic cavity can occur. Therefore, a novel shunt is being designed, which is called as vortex shunt. It has an amniotic anchor and also a bladder anchor, and because of this one-way duckbill valve, the displacement of this shunt is unlikely. This is still in the experimental stage in Stanford, and perhaps if it comes, it may show some light into the advantage of treating these megacystis as well. So, is there a possibility to do the fetoscopic erythroplasty? You can see here through the fetoscope, the catheter is entered, and then it is entered and then coming out of this external genitalia, and this urine stream also can be seen. So this is called as fetal cystoscopy for luto. In 2018, this is the paper from the EVIL, that is Paris Center, where they said that this is most useful in cases of obstructive ureterocele, and also it can be used in posterior urethral valves. However, the important thing is that most of the times the renal damage might have already occurred in cases of PUV. Therefore, fetal intervention for luto by cystoscopy, it improves the 6-month survival rate in case of severe luto, but only fetal cystoscope may prevent impairment of renal function. The challenge with the fetal cystoscope is that angulation. So as you understand, as the bladder volume increases, the urethral angle may change, and especially in the male fetus, because posterior urethral valves are more common in male fetuses, luto, that is lower urinary tract obstruction. Manipulation through this angulation becomes very difficult. That's why more and more advanced research is happening to see how this cystoscope manipulation can happen. Now, we have a pediatric cardiologist in today's meeting, I know, but also I want to share one of the cases that in collaboration with the cardiac team that we have done. This is a severe case of severe antenatal critical aortic stenosis, where there is enlargement of the global enlargement of the heart, as well as slowly it is inching towards the hypoplastic left heart. So before that, the shunting of the balloon aortic valvoplasty is done. You can see here in this, the shunt going through the LVOT and then slowly dilating, so that balloon valvoplasty was done successfully in this case. And you can see here post procedure there is a good flow, and you can see the wonderful outcome of the baby as well. So aortic stenosis still can be treated in the antenatal period, that is prenatal intervention, as well as in the neonatal period. The advantage of doing in the antenatal period is that cardiac damage, that is hypoplastic left heart, can be prevented. However, it has a pregnancy loss rate of, because the PPROMs, that is, these are common after the antenatal interventions. That's why there is a weighing balance, but more and more cardiologists, pediatric cardiologists are attempting to do it, especially the aortic stenosis rather than the pulmonary stenosis, where successful outcomes are there. Now, let us see some of the abnormalities in the placenta which can have an impact on the fetus. You can see this is a chorangioma, that is a tumor in the placenta. The fetus is innocent, but because it acts as a AV fistula, there is a heart failure and then hydrops. Therefore, the coil versus embolization of the feeder vessel of the chorangioma is done in this case. And then later baby during the process also developed the anemia. Therefore, intrauterine blood transfusion is given. And you can see that it is a successfully managed case where the placenta is the culprit and the fetus is normal. So are there any medical modalities? Till now we have dealt with the surgical treatment. So to handle the functional abnormalities, because when we said congenital malformations, it also has the functional abnormalities. Here is one of such cases, that is supraventricular tachycardia, where the fetal heart is around 240. Transplacental therapy, that is by maternal digoxin and sotalol was given, and slowly fetal heart has come down, and then she birthed a normal baby who does very well. Another case, a non-immune hydrops, where there is tachycardia and then fetal heart is up to 220. So this is the atrial flutter. If you see this CTG strip, you cannot identify the fetal heart rate at all, because the heart rate is more than 220 beats per minute. And therefore, it is a case of atrial flutter. And sometimes the atrial rate has gone to 400 beats per minute as well. So just the previous case, we gave the digoxin and sotalol to this mother, but unfortunately, women developed what is called as digitoxicity, intractable vomits and dyselectronemia. Therefore, digoxin has to be started. And then as an experiment method, we thought that, okay, the fetus has a hydrops and then we may be losing the baby, but why can't we give this digoxin into the fetus? So directly into the fetal thigh, I have given this injection of the digoxin as per the dose calculated in collaboration with the pediatric cardiologist. And we gave that injection and then intramuscular therapy for the fetus for this atrial fibrillation. And in the coming 4 days, as you understand, the fetal heart rate is come down to normal. However, at 34 weeks of gestation, this woman developed a PPROM and then birthed this hydropic fetus by cesarean section. We continued, the neonatologist continued the digoxin and then diuretics for 3 months, and baby is absolutely fine now. So these cases say that there is a role for the medical management in these cases. Also, there is fetal anemia due to the Rh isoimmunization. We are all familiar that, by giving the intrauterine blood transfusion, O negative compatible packed red cells, we can save these babies from going into hydrops and hence death as well. So this also comes under the not malformation as such, but is a functional abnormality. Another case series we had is that fetal thyroid, that is the goiter, where you can see that mother has antibodies, and then the fetus developed the goiter, and then we did the fetal blood sampling. There is the hypothyroidism is identified, and therefore the thyroid medication is given as intraamniotic installation. You can see the needle tip here. And as I install the thyroid, you can see injection, you can see the baby actually swallowing the thyroid as if it is thirsty. So this is actually a case of twin pregnancy where both the fetuses have this, goiter, and then we give the intraamniotic installation and both are doing very well. So fetal therapy in discordant anomalies in case of twins is beyond the scope. So are there any modalities available in genetic abnormalities? So here comes the issue that metabolic manipulation to mutant gene therapy. So genetic disorders have different therapeutic approaches. This particular latest articles, Advancing Precision Care in Pregnancy Through a Treatable Fetal Condition Finding List, comes last year, and it says that because we are doing not only CMA and more exome sequence and then sometimes genome sequence as well, we are able to identify some of the abnormalities in this sequence of the genes, which are actually not related to the particular condition, structural abnormality for which a prenatal procedure is done. But instead, these are incidental findings and they are the reason for adult onset disorders. And then hence this particular article proposes a criteria for the treatable finding list. These are the modalities through which the fetus can be treated by genes as well, oral medication, umbilical cord injection, amnio reduction, intraamniotic injections, and fetal surgeries. But before giving this gene therapy, these are all tested in the rodents or guinea pigs or, rats by giving this, this is the animal model for the gene therapy. Some of the examples go like dietary manipulation, inborn errors of metabolism, pathway modification, porphyrias, and so on and so forth, including tissue transplantation for hematopoietic, stem cells can be given in certain cases like perhaps, thalassemia, which is very in research these days. What are the factors leading to successful gene therapy is because it is an open fetal circulation and accessible stem cell population is there and the immune system is very naive. It can accept the gene therapy very well and permeable blood-brain barrier and of course small fetal size. And hence these are the factors which are good for us to give the in utero gene therapy. Very few conditions are amicable for the surgery, for the gene therapy these days. One of them is that spinal muscular atrophy. So it is the therapy aimed at increasing the levels of functional SMN1 gene. And then second thing is that increasing inclusion of exon 7 in SMN2 gene splicing by altering the process. Very important thing is that risdiplam was administered to an individual carrying the fetus with SMA at a dose of 5 milligram per day between 32 weeks to 5 days gestation and delivery of the fetus at 38 plus weeks of gestation. This pilot trial appears to be successful and very heartening to realize that this treatment is FDA approved, though it is not still available in India. Very soon we are going to get it back as well. And as we know, for most of us, it is the Down syndrome, which is we spend a lot of time in screening and then counseling these women. How about the having of treatment for the Down syndrome? Yes, CRISPR opens a new frontier in Down syndrome research, which says that specific targeting, the allele specific targeting and DNA cutting to increase the rate of chromosomal loss. And hence, there may be a chance that Down syndrome also can be treatable very soon. So again, and of course, the last resort, if there is a life-limiting condition like bilateral renal agenesis, and then which is identified very later, 22 to 24 weeks gestation. Those days, the 20 weeks gestation is the cutoff, MTP cutoff. And then what are the options that women can have? There is something called as fetal palliative theory. So 40% of the couples who made a positive decision to continue the pregnancy despite life-limiting condition felt relieved because this palliative care can provide feeling of avoiding the feeling of guilty consciousness. Also, they prepare themselves for the baby's death. And hence, for those couples who continue the pregnancy despite knowing that it is a lethal malformation or life-limiting condition, what is to be offered is that perinatal palliative therapy. Now we are going to the last one, that is, we all know that we do the NIPT as a screening test for so many conditions. And hence there is a project which is coming as Maternit Genome, non-invasive genome. So why not? The future of NIPT is going to be universal whole genome sequence, where perhaps, I do not know, designer babies may be, selected by the couples as well. Because once you have DNA, anything is detectable. But leaving away the dreams and then advanced frontiers, we should not be losing what we are supposed to do, the minimal non-negotiable treatment, that is folic acid, steroids as and when required, magnesium sulfate for neuroprotection, and perhaps aspirin for the prevention of preeclampsia or fetal growth restriction, and antivirals and antibiotics whenever there is infection. This is some non-negotiable thing for us. So the key messages for my, the talk today is that fetal therapeutic options are now available And then gene therapy is very, very exciting and developing front, already proved in conditions like spinal muscular atrophy. Of course, a multidisciplinary team, including many of the specialists, is very important to deliver these goods to the special couple who carry children with special needs. So the question is that congenital anomalies, a ray of hope? Yes, of course, not so far distant horizon. Thank you very much, GOGS, for this opportunity. Thank you all.
Thank you, Sushila Madam, for such an insightful and enlightening presentation. I'm very happy that more fetal medicine specialists are coming up because it's making obstetricians work easy. Madam, I have two questions. Can I ask now or later?
Whatever the organizers say, madam. Definitely. Thank you for the kind words.
Yeah, we
Madam,
can
I
take
have-
queries in the last, ma'am.
Yeah, no problem. I'll ask in the last.
Okay.
One word regarding Susila.
Sir.
She is my student.
Yes,
So
sir.
special congratulations to you.
Thank you,
You're
sir.
a national speaker. Definitely. You improved a lot and you are doing a lot of work.
Thank you, sir.
So finally you told the preventive aspects also, that I'm very, very happy, because whatever it is, what we are going to do, the society in general is more important, but you are doing very specialized work. So we should not forget the folic acid and other management, neuroprotection, all those things. So actually, the key message for this year is every journey matters. Every journey matters. That means every child and every family should have a support, and access, and equality and equity. So that is the saying for the present year. So it is not only the preventive aspects. So we have to understand the family. So every anomaly has a story behind it, seems. So because in the periphery it's very difficult to counsel the parents regarding any anomalies. So I think you are doing a very good work. Congratulations once again.
Thank you, sir.
Yeah.
Thank you, sir.
Thank you, Sushila ma'am, for the insightful presentation. Now, I introduce our Jyoti Prakash sir, consultant and interventional pediatric cardiologist at Aster Ramesh Hospital. And the sir's topic is from fetal heart to childhood, tackling congenital cardiac defects. Sir will be dealing about the cardiac defects, which can be prevented when we diagnose in the antenatal period, and the management successful outcomes of the congenital cardiac defects which were managed. Now, I invite Dr. Jyoti Prakash sir for his presentation.
Thank you, Anuradha ma'am. Thank you, Shama ma'am. Am I audible? Sorry.
Yes,
Yes, sir.
So thanks to everyone who provided me this opportunity. So I think it's a right platform for me to introduce our pediatric cardiac activities, what a pediatric cardiologist can deal. So my screen is visible?
Yes, sir.
Yes, sir.
Yeah. Thank you. Today my topic is about the fetal echo to postnatal, the continuum of care. So why do we need to worry about the congenital heart disease? So if you see the overall incidence, it's 88 to 11 per 1,000 live births. Means that is 1 in 100 births. Here means almost 1% of the routine live births has the incidence. But if you compare to other birth defects like chromosomal anomalies, it is 6.5 times of routine incidence, and when compared to neural tube defects, it is 4 times. And if you compare to the routine screening, usually we do after birth, immediately after birth, the TSH, the congenital hypothyroidism, it is almost 32 times of routine. So the other thing is we need to think about this one is it almost contributes to 30% of the neonatal mortality, and if you compare the overall infant mortality, almost 10% of mortality is just because of the critical congenital heart diseases. And even in the postnatal life, it is proven that many of the critical congenital heart diseases like TG and all, though they are very critical congenital heart disease, they may not be detectable on routine physical examination unless you do a proper detailed screening. Otherwise, in general OPD practice, definitely almost 1 out of 4 cases are going to be missed, and they will be landed up with the sudden scenarios, and definitely you are going to lose the babies. So, and if you see the congenital heart disease, almost invariably, almost every congenital heart disease has some amount of treatment, whether that might be a surgical, interventional, or whatever. Even if it is a staged surgeries, there is a some amount of treatment is available for almost all the congenital heart disease. But due to lack of early diagnosis, sometimes we are missing the links. So I'm going to discuss today about the role of prenatal diagnosis. Why we need to do means, first we need to identify the at-risk individuals, and then we have to think which one needs intrauterine management and which one need to be in the perinatal period, and what should be there for to be prepared for perinatal area, and in the perinatal period what preparations has to be done, and finally the counseling of critical and non-critical congenital heart diseases. So I'm going to discuss in form of clinical evidence. So before that, how when you are going to do fetal echo. So ideally, the ideal time is 18 to 24 weeks. Though you can see the actual cardiac activity by 6 weeks of gestation, but up to at least 16 weeks only you will get a satisfactory cardiac imaging. But sometimes you might get even at 14 weeks, but ideal time usually it should be between 18 to 24 weeks. And beyond 24 weeks, sometimes there are limitations because of persistent fetal mobility, calcified ribs, calcified spine, or oligohydramnias, or because of high maternal BMI. Sometimes you may not get a proper imaging, but beyond 24 weeks, some of the conditions like TAPVCs and cooptations are actually better visualized beyond 24 weeks, but they might be missed, or sometimes you will have only indirect evidences before 24 weeks. But definitely, whenever you are having any indirect markers of these things, you should repeat after 24 weeks. But imaging, direct imaging of fetal echo after 24 weeks, definitely it gives improper report only. So then what is the role of first trimester echo? So sometimes when you are having doubt in case of like hypoplastic left heart syndromes, sometimes we ask for early first trimester echoes, usually done between 11 to 14 weeks. After 10 weeks, you can have a 4-chamber visualization, including the IVC. And sometimes by 12 weeks, you'll start seeing the outflow tracts. But definitely, I generally do not recommend this one. This is only for the 4-chamber view, first trimester echo. The outflow tracts, though may be visible, may not give an appropriate actual scenario of the outflow tracts. But the 4-chamber, if you see anything, hypoplasia, the ventricular discrepancy, definitely you can identify in the first trimester. And always you have to repeat at least after 4 to 6 weeks whenever you are having any doubt about the first trimester echo. And this can be done by transvaginal transducer or high frequency transabdominal transducers. So then intrauterine management, I'm going to discuss with in the clinical weakness. So here one mother, 28 weeks gestation, maternal SLE, recently diagnosed, and having twin 1 is having low fetal heart rate, and twin 2 is having normal fetal heart rate. So we counsel them. So this case was referred by Dr. Sumalata Garu from Rainbow. So when we saw that there is significantly the heart rate is on lower side, 53 was the heart rate. So yes, if you see the fetal images, definitely the heart rate is definitely significantly low, and there is because of some amount of ventricular dysfunction. You can see that there is a moderate TR. The other twin is having significant normal heart rate, 167 was there. So in the interest of second twin, we started the mother on steroids and hydroxychloroquine. At 30 weeks of gestation, the fetal medicine people, they noticed the other twin is having fetal growth restriction. So sometimes we might see this when we started on steroids, they'll have some amount of fetal growth restriction. So it was managed, but on the interest of another twin, this induction was planned. So the twin were born with a weight of 900 grams with low fetal heart rate, and twin B is having 1.1 kg with the normal heart rate. So this is the ECG of the baby at birth. So you can see that there is a 3:1 block. The atrial rate is very good, around 200, but ventricular rate is less than 60 per minute. But when you see there is no correlation between the P and QRS complex, so this is a third degree heart block. So this is the baby, so with weight of 900 grams. So when you see, so initially we started with the adrenal infusion, but on day 3 we noticed that child is developing some amount of ventricular dysfunction. So now we counsel the parents, so the need, but now after birth the parents want both the babies. So we gave them option that there is a possibility of temporary pacemaker insertion, because the Microni which is available in India, it's only for about 2 kgs. Less than 2 kgs, the no permanent pacemaker was available. So this one, then we introduced temporary pacing wires. So then we externally connect with the pacemaker. So we started the child on pacemaker in programming. Then after attaining 2.5 kgs, this is the pacing generator. The right side you can see the pacing generator and pacing leads. So we introduced in the xephisternum. So the child was pulled to up to 2.5 kgs. Then we did permanent pacemaker. Right now the child is 7 years age and we are doing well without any issues. So we are following 6 months in 6 months with pacemaker programming. So this was the youngest child of this one. So in worldwide, if you see this, the youngest young baby with who underwent this pacemaker, it is at 10 grams, and our baby is 900 grams, the second best one. So whenever you are seeing any fetal bradycardia, definitely you need to see whether there is a 1:1 conduction or more than 1:1 conduction. And if there is identified structural anomalies like heterotaxis syndromes or AV canal defect, all those things, you need to rule out. If it is normal, then you have to look for maternal connective tissue disorders. So whenever you are having any connective tissue disorders, definitely the steroids and hydroxychloroquine are going to help. Whenever you are connective tissue disorders are ruled out, you have to differentiate it from long QT syndrome. Because why we need to differentiate? Because the steroids and the beta agonists are going to help in maternal connective tissue disorder, means autoimmune congenital heart diseases. But long QT syndrome, the beta agonists are actually contraindicated. There, the beta blockers are going to help. So to avoid beta agonists, you should rule out whether this fetal bradycardia is because of autoimmune block or long QT syndrome. So another example is 22 years primary, 32 weeks, detected to have a fetal tachycardia. So you can see that there is a heart rate is around 200. So the atrial rate is much higher than this. So this one mother started on digoxin and sotalol. So the child. So this is actually we haven't done this one. This is actually the intrauterine we are giving digoxin therapy. So intrauterine therapies are available with both the digoxin and amiodarone. Particularly whenever you are having SVTs, which are refractory, usually when the baby develops hydrops, definitely better to go for earlier termination of SVT. Otherwise, you are going to have a cardiomyopathy because of tachycardiomyopathy. They can have a bad prognosis. So this kind usually digoxin and sotalol and another option is flecainide. Flecainide generally I avoid whenever we are anticipating atrial flutter. But other short VA tachycardias, definitely they are going to help with digoxin and sotalol combination. So whenever you are giving digoxin, so always check maternal digoxin levels. If they are going beyond 2 gram per deciliter, definitely it's having uh, dramatic effects onto the mother side. So in that in those scenarios, it's better to go for direct intrathecal intrauterine therapies with the digoxin. So this after digoxin, the fetus has very good improvement. So the heart rate has came down to 162. Still, there is some amount of atrial discrepancy. By the time child born, it was showing. So short RP tachycardias. So then this was terminated with DC shock, and the child was continued on beta blockers with digoxin. So this is at the time of discharge. You can see that the rhythm is sinus. So whenever you are having a fetal SVT, always you need to differentiate whether there is a hydrops or not. Whenever there is a hydrops, so when in non-hydropic fetuses, definitely if it is a short via tachycardia, digoxin and flecainide are the options. In flutter, better to avoid flecainide. Both digoxin and sotalol can be given. In ectopic atrial tachycardias, flecainide and digoxin are the choice. Flecainide being the first part, and PJRT, flecainide or sotalol. Whenever there is hydrops, always better to go for combination therapies. And fetal therapies are available, so you can. But nowadays, nobody is planning this cardiosynthesis because of high chances of morbidity or fetal demise. Intramuscular onto the thigh or buttocks are preferred therapies, or sometimes the amiodarone or digoxin can be given intraperitoneal in case of refractory SVTs, fetal SVT. So whom we need a perinatal preparation and management. So definitely all the fetal therapies, whenever you are having this one, like rhythm issues, definitely they can be managed in utero itself, and most of the times before 34 weeks itself they can be managed. But whenever you are having structural anomalies, like actually some of the people are doing as Sushila madam showed, in case of aortic stenosis, in case of pulmonary stenosis, or in case of hypoplastic heart syndromes, they are doing in intrauterine therapies. But if you see overall the mortality compared to this one, other normal babies, definitely the overall morbidity and mortality are high. So whenever you are having these conditions, you should prepare the parents, including the mother, for elective induction, and they are to be supposed to be delivered at a center with pediatric cardiology, particularly when it is a duct dependent cardiac lesions. So here are 32 years primi gravida with 28 weeks gestation. You can see that there are two parallel circulations. So this is a detransposed great arteries, and the ventricular septum is intact. You can see that there is a confluent branch base with the flow reversal in the ductal arch. So the ductal, whenever you are having any duct dependent congenital heart disease, always our aim is to maintain the ductal arch. The ductal arch is important, and foramen valve. These to be mentioned in the final diagnosis also. So these two means ductal arch is much more dynamic structure in fetal life. So whenever you are means some of the conditions like NSAIDs and all, whenever your mother is receiving all those things, definitely high chances for premature ductal closure. So these things to be avoided, and you have to maintain this ductal arch. So parents are counseled about the possible corrective surgery, and because TGI is a very having very good prognosis. Previously, the mortality was around 30 to 35%. Now it came down to less than 5% in TGA. So we informed the same to the parents, and we advised them for delivery at our center. So this happened before COVID times. So we gave CMRF to the parents before baby's birth, and by the time they got CMRF. Baby was planned electively, and immediate postnatal echo showed that baby birth weight was 2.8 kgs. So we managed a baby, and at 48 hours of life, we saw the saturations are declining. So it was 75%. So we stabilized initially with prostaglandins and then planned for surgical intervention. So the babies underwent surgery safe. So having no issues in the immediate postoperative period, and finally discharged on day 6 itself with the healthy hemodynamics. And on follow-up also, child is thriving well and healthy, and there are no residual cardiac defects, and followed up to 5 years, and till now no issues for the child. So here is another 25 years lady with 30 weeks gestation. The fetal echo showing top with pulmonary atresia, and here this is also a duct dependent pulmonary circulation. So here our main motto is to maintain the branch PS along with ductal arch. So if the ventricles are adequate size, definitely they are having a very good prognosis. In case of hypoplastic heart syndromes, you will have little guarded prognosis, but whenever you are having adequate sized ventricles, definitely you are having good outcomes. So this is you can see that there is a overriding and a flow reversal at the ductal arch. So by the time baby birth, its birth weight is 2.1 kg, and we notice saturations of 65%. So as the baby is less than 2.5 kg, so we went for palliative procedure. Initially, we counseled the parents about the stabilization. Then we gave them options about the BT shunt as well as PDA stenting. Both are available. So then this child underwent PDA stenting. This is the descending aortic. Okay. So descending aortic angiogram. So it is demonstrating the PDA, which is communicating with the branch pulmonary arteries. Then coronary stent was introduced at the PDA, and the PDA patency was maintained. So the other options available are whenever you are having hypoplastic PA with at least some antegrade flows, RVOT stenting can be done. In other duct-dependent lesions, Belian septostomy also can be done. This is for duct-dependent pulmonary circulations. Whenever you are having duct-dependent systemic circulations like cooptation and all, so there are other options like balloon cooptoplasty, or there's another case, coct stenting was done for the newborn baby. These both are dealt in cath lab. So other options available are coct repair. Now the overall surgical mortality is much lesser, less than almost like a 3% in good hands. And other options available. Sometimes if you are sometimes they have good collaterals. Here this is another 50 years lady who was missed in the initial stage, and you can see that there are good collaterals in the posterior aspect. So underwent means coct stenting in the later part of it. So always whenever you want to prepare anywhere, so you need to have this kind of team. So who can diagnose in the initial period at TIFA itself the fetal medicine persons and fetal cardiologist and obstetrician who can manage the labor normal, whether it is a normal or cesarean. Whenever you are having a duct dependent cardiac lesions, definitely it's better to cut down the second stage of labor, and you have to avoid prolonged labor. And immediate after birth, the NICU team and whenever required, a cath lab team by pediatric cardiologist or surgical team by pediatric cardiac surgeon definitely is going to give a healthy baby to the parents. And throughout the time, so the pharmacological management is equally important. So after birth, if at all any non-critical congenital heart diseases are diagnosed, definitely the ASD, VSDs are going to be means that doesn't need much interventions like surgical interventions. They can be dealt in the cath lab, less invasive, and even this balloon aortic valvuloplasties, all this can be managed in the cath lab itself. Even the critical congenital heart disease like coronary cameral fistulas, the pulmonary AV fistulas, all can be managed in the cath lab. So there is no doubt about the surgical mortalities. So the overall mortality with the congenital heart disease now is far less. So finally, we need to counsel which patient needs which baby needs immediate management, which baby needs just follow up, all those things to the parents. So whenever you are coming across the persistent LSVC or small muscular VSDs, mild PS, bicuspid aortic valves, these are benign lesions. Doesn't need immediate postnatal evaluation, but you can evaluate at one point of time. These are not usually not to doesn't need any interventions. And whenever you come across with VSD, ASD, or coarctation, non-obstructive TAPVC, they are single stage interventions and, and having a very excellent prognosis. And when TOF, TGA, DORV, or obstructive TAPVCs and neonatal coarctations, they definitely have overall survival rate into the adult is around 95%, but still another 10% chances for redo interventions, but they have very good prognosis. And in case of TOF with pulmonary atresia or truncus, complex DORV or single ventricle physiology, the anatomical repair with conduits or single ventricle pathway are required. But here also the overall survival into the adulthood is around 85%. Some definitely this needs invariably redo interventions, but overall prognosis fair enough. Guarded prognosis is particularly in hypoplastic heart syndromes and heterotaxis syndromes, complex pulmonary atresia with non-confluent branch PS, and neonatal Epstein's with RVOT anomalies and myocardial pathology, which usually have very guarded prognosis. Majority of the times, the first procedure to be done for them is instead of doing, there are palliative procedures are available, and with the palliative procedures with the staged interventions, adulthood life is okay up to in 70% of the cases, but in 30%, it's almost like a 30 to 40% mortality will be there at each surgery. And less than, though these 70% people born, particularly the female child, they may not undergo pregnancy in the future period. So that's why unless parents are damn interested, these kind can be considered for terminations. And here the redo interventions are invariable, just like other because it's a palliative procedure, whatever we are doing. So final take-home message is more than 85% of the congenital heart disease can be diagnosed in utero, and almost all congenital heart disease has some amount of intervention, whether that is a surgical intervention or palliative or cath lab intervention. But there are invariably all congenital heart disease has some amount of management, and proper prior planning has to be started in utero. That this is at approximately around 20 to 24 weeks, and 80% of the congenital heart disease can be that's which comes around ASD, VSD, PDA, the pulmonary stenosis, aortic stenosis. They are well managed in cath lab, and overall post-procedure mortality with all congenital heart disease is less than 5% now. Thank you.
Thank you, sir, for the insightful presentation. So now everyone knows that the cardiac anomalies are treatable and only hypoplastic left heart and severe anomalies are for termination. Others can be treated successfully in 80%. Thank you. And Sushila ma'am also, thank you for the insightful presentation, ma'am. Ma'am Rajkumari ma'am, Venkat sir, any questions?
Yeah, recently I have a case. It was at 13 weeks in ultrasound. They gave after seeing nuchal translucency was normal, but they said the nose was very short, shorter than what we see in normal. So how do we counsel the lady?
Ma'am,
We have done
Sushila
two
ma'am, you want to
scans.
take?
We have
Yeah.
done 2 scans. After 15 days, they have given the same report. Others, triple marker, all that were normal. Only the baby had, the fetus had very short nose.
Yes, ma'am. Thank you for the question. Actually, in the first trimester, the Fetal Medicine Foundation says that it is the presence or absence of nasal bone. We do not measure the nasal bone in the first trimester because nomograms are not there. And other thing is that it is a very small speck-like calcification. So if we stick on to the Fetal Medicine Foundation, guideline properly, image quality, proper magnification where the image occupies 75% of the screen, and then the ultrasound waves hitting parallel, then identification of nasal bone alone is enough in the first trimester. This is in the mid-sagittal plane. Whereas from the second trimester onwards, from 16 weeks of gestation onwards, we have the nasal bone length nomograms. So they are available on the perinatology.com website, free website. So the protocol is that if in the first trimester we do not see the nasal bone, is structural normal, everything else is normal, and then other markers are normal. If she otherwise belongs to the low risk population, low risk category of Down syndrome, then we can recall her at 16 weeks onwards, anytime, where nasal bone length can be measured. If the nasal bone length after 16 weeks of pregnancy is less than 5th centile, then it is a hypoplastic nasal bone. The options can be either NIPT or going through the invasive, provided they wish to take 1% risk of miscarriage. But nose cannot be measured anytime, and nasal bone should not be measured in the first trimester. In our experience, we identified 80% of the cases when nasal bone is not identified or seen properly in the first trimester according to the protocol. By the second trimester, they came around 16 weeks of pregnancy. In 80% of the cases, nasal bone is seen as well as of sufficient length. So I always give this information to the couple and reassure them and recall them at 16 weeks.
And another thing is, when we are doing a triple marker, you get as intermediate risk. And again, when we do NIPT, it comes as low risk. But again, when we are doing TIFA, there is some anomaly. Now, how do you assure the patient?
Sure. Pregnancy is a continuum process. Okay, if single scan at 13 or 20 weeks can give entire information, entire growth and development, we don't need 9 months of gestation, isn't it? So having said that, as you said, the first trimester scan, if it is low risk, intermediate risk, then we can give them an option. Intermediate risk means like what? 1 in 100 is high risk. Okay, 1 in 1,000. Like if it is 250 is what we take for Indian population. Anything more is, that is less number, is a more risk. Okay, and if it is like between 1 in 100 to 1 in 1,000, it is called as intermediate risk. If the otherwise structurally fetus is absolutely normal for that period of gestation, NIPT is the best option. And what happens in the TIFA scan, nobody knows. Even when we do amniocentesis in the second trimester for a different reason, in the third trimester, there can be some abnormalities like GI malformations or renal malformations. They cannot be identified in the first or second trimesters. Also, as sir has said, ductal aneurysms, these kind of things, or coarctation of aorta sometimes may be picked up in the third trimester. So there is a possibility that third trimester also can reveal us some abnormalities. So that's how we reassure them that anytime, every time we say that for this period fetus is normal. However, as per the protocol, third trimester we wish to see again.
Thank you, madam.
Okay.
Ma'am, Sushila ma'am, some questions in the chat box. In the first trimester screening, how do you integrate NT measurement with biochemical markers to improve early detection of structural anomalies beyond aneuploidy?
I do not integrate biochemistry for the abnormalities, structural abnormality exclusion. I trust in my technique. I trust, myself in seeing technology. And then sometimes with the fetal position, we may have some constraints in imaging, but Screening is different from, identification of congenital malformation. Scan gives information about the structural abnormalities. Biochemistry gives us an idea about the enhancing the screening value. And as a matter of fact, double marker test is not the order of the day. It is called enhanced first trimester screening, which includes free beta HCG, PAPA, as well as the PLGF, which is integrated to identify, along with the structural abnormalities, all the standard markers of the Fetal Medicine Foundation and uterine artery Doppler. This gives us an idea about common aneuploidies. So the purpose is for calculation of expected date of delivery, then identification of twins and then chorionicity, exclusion of major congenital malformations, and then screening for common aneuploidies. So in this regard, aneuploidy screening forms the last one. Structural abnormalities have to be identified by the standard planes of imaging, and then only we can go for the screening. For example, if the fetus has omphalocele, it is already at a higher risk of having, a chromosomal abnormality. So no need for other, markers at that point of time.
Thank you, ma'am. What is the current sensitivity of targeted early anomaly scans like 11 to 14 weeks for detecting major cardiac and CNS malformation? So current sensitivity of early anomaly scan in detecting major cardiac and CNS malformations.
Yeah, it depends upon the various centers, and also on your checklist. If you have the four-chamber view, as our sir has mentioned in that, then you may identify lethal malformations. But if you also have the V sign, what we call to identify the major conotruncal abnormalities, then it is possible to identify. It depends upon what type of protocol you are adhering to. If spine imaging is a part of your protocol, then it's high likely that you would identify the open neural spinal defect in the first trimester itself. If spine is not a part of your protocol, then you don't even look at it, isn't it? So actually it goes by the protocol and checklist that you follow.
Next question, how should early diagnosis influence timing and mode of delivery in cases of major congenital diaphragmatic hernia or neural tube defects?
Neural tube defect is very tricky, isn't it? Actually, the videos and all that I showed are the moms, that is, multiple myeloma surgery is not come to India yet. Amrita Institute of Medical Sciences in Kerala is geared up in case, anybody is willing to continue the pregnancy. Whereas optimizing time, most of the times what happens is closed spinal defect may not be identified or missed in the mid-trimester. So these are the cases that we pick up in the third trimester, and then in the absence of cerebral signs like banana sign, and then if the cerebellum is normal, cisterna magna is not obliterated, then the prognosis is going to be good. But at the same time, there is lot of morbidity. It is not the challenge with the neural tube defect is that the IQ of the baby is intact, so they know what they are going through. However, they can have motor disability or bladder and then bowel, poor control. That is actually devastating for them. There is no optimization of time in the neural tube defect. Then coming to the second thing they said about the diaphragmatic hernia. Yeah, so
Congenital diaphragmatic hernia.
yeah, congenital diaphragmatic hernia is extremely treatable condition, post birth. The only thing is that we have to make sure that there is no abnormality, chromosomal problems in the mid trimester, or there are occasions where we have picked up in the first trimester as well, and there are occasions where we have identified in the third trimester as well, because only the mediastinal shift sometimes gives. If it is a stomach which is herniated into the hemithorax, then it is easy to identify. That is left-sided diaphragmatic hernias. Whereas if it is a left-sided diaphragmatic hernia with a small bowel herniation and stomach is still in the abdomen, it is there is a high chance that we may miss it. Just because the reason is that stomach is below. Okay. Whereas one has to be, while doing the TIFA scan, we have to be very careful about the mediastinal position. In cases of subtle herniation of small bowel, still the heart, which is rather in the middle mediastinum, it may be shifted to the pseudodextrocardia, that is right side. This should give us the hint to recall the women very soon, like 22, 24 weeks, to identify the bowel and peristalsis in the hemithorax as well. Extremely rarely, there is a need for the MRI to see whether it is, really herniated. You have a strong suspicion clinically, that means on the ultrasound, and therefore you may ask for that. In these cases, lung head ratio is very important, and observe to expected ratio with the prognostic signs. Again, perinatology.com, you can follow the calculator, because my time doesn't permit to go through each condition. Each condition actually is a kind of talk or, sharing the experience. And if it remains normal, then the women can be given an option of birthing, vaginal as well, because this is not alone indication for C-section. Having said that, timed delivery is sometimes important. We have to make sure that the neonatologist is available there, and the information about the diaphragmatic hernia has to be passed on to the neonatologist, because in case the baby has low Apgar, the CPAP should not be given in these cases. We will be, doing more harm by subjecting the neonates to the CPAP. And therefore, to suit to the timings of the practitioners and then, the parents, most of the times the surgeries are done. And soon after birth, the neonate is ventilated. And after stabilization, they will take the baby for the corrective surgery.
Okay. Next question, ma'am. Where does NIPT stand today in detecting micro deletions and single gene disorders, and what are its limitations in routine practice?
It is close to the horizon. Today, where NIPT stands is that strongly for the Down syndrome screening. If you ask me, the policy should be like first trimester scan is mandatory for everyone. We don't want to see the anencephalus in the labor ward anymore, isn't it? So first trimester scanning is mandatory, and to complement it, the EFTS, enhanced first trimester test, is like cost effective policy for across the even Indians as well, most of the Indians as well. But apart from this, if at all any need is there, like intermediate risk, she asked, the other man, Dr. Rajkumar asked, like NIPT can be there. But if a woman misses the first trimester screening, I would rather watch for a 14 weeks or 16 weeks thorough scan, anatomy scan, to exclude major abnormalities. And I would rather go for the NIPT rather than quadruple marker test. Triple marker test is gone out of the window. Quadruple marker test is on the way out. There, if a good anatomy scan can exclude most of the major congenital malformations, maybe up to 70% as well. And then what we can't see is the chromosomes, and therefore rather than the quadruple marker test, because it doesn't give any information about the perinatal, adverse perinatal outcomes. Whereas first trimester EFTS, PLGF, placental factors can give us a light on the preeclampsia. So I would rather invest the women's money on NIPT if she misses the first trimester, because preeclampsia, etc., again the biochemical markers, S-split, PLGF ratios in the third trimester are ranking in the third trimester, because we also have to look at the adverse maternal outcomes here. So that is where NIPT stands. It is 99.9% accurate for the Down syndrome detection.
So the message is that everyone should do first trimester screening along with enhanced first trimester screen, including preeclampsia screening with PLG. So
it's
that
not
we
just a
can
double
prevent
marker. Yes, it's not just a double marker
where
test.
it detects. Yeah, it should include both the beta HCG, PLGF, and PAPE, so that we can predict preeclampsia more perfectly, and we can treat those people not to get high blood pressures by giving echosprin. Ma'am, last question. How can structural anomaly scan protocols reduce inter-observer variability and missed diagnosis? So you should have a protocol. How
Yeah, you
can
should have.
structured anomaly scan protocols reduce inter-observer variability and missed diagnosis?
Okay. Maybe Anu, I can say that by having the checklist, a strictly protocol, having the checklist and sticking on adhering to this checklist, and then maybe wonderful CMEs like this, where people get more knowledge, and hence the chances of missing anomalies will be minimized. It is more of practice.
Thank you, ma'am. Thank you, Jyoti Prakash sir. Thank you, Sushila ma'am,
Thank you,
for
ma'am.
your valuable time. And
Anu, am I allowed to share my screen just for a minute because somebody asked
Sure,
this
ma'am.
question? So, are you able to see my screen? This is the ultrasound checklist. And then ISWOG, and then other ISWOG has online available checklist for the first trimester as well as the second trimester.
Yes, ma'am. This is for first trimester scan you have kept.
Yeah. So the first trimester efficacy, is what they have asked. In this, acrania, body stock abnormalities, ectopia cardis, and then exomphalos, gastroschisis, megacystis. These should not be missed. These have to be identified always in the first trimester, and then so on and so forth.
So everyone should do this checklist when they have to do NT scan, so that they can detect major abnormalities.
Thanks to the NIPT, actually, the role of first trimester scanning is to identify the major congenital malformations as well as correction of the expected date of delivery. Gestational age determination, very important.
Yeah. NIPT also, it's only a screening test that should be known to everyone. It's not a confirmatory test. And NT scan first has to be done NT scan before going for NIPT or biochemical screening. Only there is no structural anomaly and NT is normal, we can go for biochemical screening or NIPT. Rather than going nowadays, everyone is getting NIPT done at 10 to 11 weeks, ma'am. So I'm surprised to see that. So I'm telling everyone first get NT scan done, then only screening, because NIPT is also a screening test, not a confirmatory test.
100%.
If there is structural anomaly, we can't assure only NIPT where we can detect only Down syndrome, that to 99%.
Yes.
So screening is very important. Structural anomalies are not there, then only we can go for biochemical screening.
I'm
Thank
with you,
you, ma'am.
100%.
Thank you, sir.
Thank you. Before we close this session, we have a request from MediSage people that they want to share their slides for Sage AI. Yeah, Neetu, you can go ahead.
Thank you so much, Shama ma'am, for this opportunities and respected faculties. As in the introduction, I have already mentioned about Sage AI. It is an AI tool we have created for clinical practitioners and doctors to help them in their daily practice. Let me show you a short demo of how the Sage AI actually works, and you can also let me know your opinions for the same. First of all, the Sage AI is available on MediSage app. You have to download this MediSage app from App Store or Play Store, and then this is the home screen. This is the laptop screen that you are seeing. The similar screen will be available in the home screen also. So on the left hand side, you can see Sage AI. So we have entirely renewed the Sage AI section. Here on the left hand side, you can see all your previously searched deep research prompts, and also whatever presentations you have created, what are prompts you have given. This is your chat history basically, and on the top right corner you can see the points left. As and when you use each of the features, the points get detected from here. Okay, right now it is for new users of the app. Okay, so this is stage A, and we have five to six features in the stage A. So let's get into the first one. This is diagnostic support. Here, when you enter a patient history or symptoms or past medical conditions, here in the upload documents, you can even enter the blood reports, scan reports, the MRI reports, ECG reports, everything, and then upload it here, and then you can just click on diagnosis. For this demo purpose, let me share one example. It won't take much time. Yes. So here is the case. It's a hormonal imbalance in a 28-year-old woman. Miss P, a 28-year-old woman, presented with complaints of irregular menstrual cycles, acne, and recent weight gain over the last 8 months. She also reported mild hair thinning and occasional mood swings. There is no history of thyroid disorder, diabetes, or significant stresses. She leads a sedentary lifestyle with BMI of 27 kg per meter square. So examination report is also shown here. General, well-oriented, mildly overweight, acne over face and jawline. Vitals, pulses 80 per minute, BP is 118 to 76. Thyroid, no enlargement or tenderness. Abdomen observation, mild central adiposity, no organomegaly. And then pelvic examination is also here. Ovary slightly enlarged and mobile on bimanual exam. So this is the case. I would request the faculties present here to kindly, diagnose it from your end. What will be the diagnosis of this? And we will ask the diagnosis stage A also. What will be this? I am just entering a gynae case report. This is just the blood report I have entered here. So now once this is done, let me just click on get diagnosis support. So it will be taking 1 or 2 minutes since it's searching its database, all the medical records that it is fed, all the medical data, and then it will give you the proper diagnosis. So the highest diagnosis stage is given is PCOS. I hope all the faculties over here has guessed it right, ma'am? Any replies? Hello?
Yeah. Yes, we have guessed it.
Yeah, so it's PCOS. The medium probability can be NCCAH or the ovarian or androgen secreting tumor. So what basically does is it is reducing the cognitive load of doctors. So if you're seeing high probability might be PCOS, then you can investigate on this way of a patient treatment. Below, if you see, we are also giving recommended investigations and also what next steps can be taken in this case. So this is how the diagnostic support basically works. Moving on to the next one, drug interactions. Here, if you are entering two drugs, any two drugs, which will be in case of pregnancy or in any particular condition, it will show you the whether the two drugs will have major interaction or mild interaction between them when given at one go. Okay, let me just give you a slight example over here also. So one is magnesium sulfate and the other is nifedipine. So check interactions. So as you can see, It has given severity is major. These two drugs have major interaction between them. The reason, the mechanism, everything is mentioned here, and advice also. So this is how drug interaction works. Basically now only two drugs you can enter, but we are working that you can enter more than two drugs also, since when the patient is in ICU or in critical conditions, there are chances that more than two drugs are given. So we are working on that as well. Okay. Next feature create presentations. So this is a really good feature for all the academically oriented doctors. Once you enter the topic over here, let me enter a topic, fetal growth restriction. You can enter number of slides. You can create up to 30 slides in the Sage AI. For the time being, I'm creating 5 to 10. Languages, English, Hindi, Marathi is available. I'm selecting English. Audience, to whom you're addressing your presentation. Is it medical professionals, medical students, or patients? Currently, it's medical professionals, and tonality of the presentation. You can select professional, conversational, or academic. Administrative professional. Here also you can add additional document, any book pages or research papers you want it to include, you can just add it over here. Just create, select on generate outline. It will be generating the outline of each slides, which is editable. You can edit any of the content over here. You can add any content here, and once it is done, the slides will be generated. So yeah, here is the fetal growth presentation, 5 to 10 slides that it has created. As I said, if you click on the edit button, you can make the changes over here, and then just click on the right button. Okay, the references is also given here, from where this Sage AI has taken all this information. This references is what actually take time for doctors. So it has also mentioned the references. You can just click on it and refer to the article or research paper Sage AI has referred to. So here is the presentation. Once you click on generate slides, the slides will be ready for you. You just have to copy this and then paste it in your PowerPoint presentation. This is how simple is to create presentation now for all the doctors. The next one is deep research. Here you can, if you want to publish a research article or publish an article or research paper, basically, there is you have to refer to many research papers, articles, what are the latest guidelines, this and that, everything. It takes hours of work over here. So here what it will do is, if you enter a particular topic over here, all the research work will be done by Sage AI, and it will give you the latest reports or research papers connected to that. Let me take biologics in severe asthma patient. The prompt given here itself, how the deep research works basically. I will show you that. Yeah. Sorry. Okay, sorry for the disturbance. So here it is the deep research work that Sage has presented for you. It has executive clinical summary, introduction and background, pathophysiology, everything with citations. So at the end of the deep research thing, you will get all the references from where Sage AI has taken each one of the points it has mentioned. So you can easily click on the references and okay, the detail is really big. Yeah, here are the references. So mostly it is from PubMed, NCBI site, from latest research papers that they have taken the references. So you can just click on it and refer to which article or research paper Sage AI has referred to. This is how deep research works. And then drug dosage. So here, if you enter the drug name and condition of patient, and what is the patient type, if it's pregnant, if she's pregnant, pediatric, adult, or lactating, it will show you what amount, what dosage of drug can be safely given over here. So let me enter a drug name, methyl dopa, and the condition first trimester. Then patient type, she's pregnant, and then just click on over here. So it has, first of all, it has given methyl dopa is a recognized and valid medicine. Then the dosage information, the route, frequency, initial dosage, titration, everything is mentioned here, and also the precautionary measures of this particular drug is also mentioned over here. So this is how drug dosage is works. And in here, ask anything. You can ask any additional questions to Sage AI, and your doubts will be cleared over here also. Okay. Now last is patient treatment plan. This is an amazing feature which we have recently launched, like 2 to 3 days back. So in patient treatment plan, there is a voice input, and there is one called as type patient case. You can actually record your voice over here, and it will generate a patient treatment plan for you. For now, since I'm not a doctor, so I will be just for the demo purpose, I will be entering a simple case over here. So let me start. Allow this time. So there is a 4-year-old male patient. His name is Aditya. He is suffering from breathlessness and congestion in the chest for the last 3 weeks, and also has cough inside him. He is visiting for me for the first time. That's So now let's see. You can give as much detail of the patient to this Sage AI, and it will generate patient treatment plan accordingly. Now for the time being, I have given very short description. So here you can see patient information. It has catched a 4-year-old. He's a male patient suffering from whatever symptoms I have mentioned: breathlessness, congestion in the chest, last 3 weeks, along with cough. Medical history has mentioned, first time visitor. This also I have mentioned, past medical history. Condition, it might be respiratory tract infection or bronchospasm. Diagnosis, subacute bronchitis. Examination not mentioned in the conversation. I haven't mentioned any examination. Impression, what will be the impression of this patient? Investigation, what further investigation can be done in this case? CBC is preferred, a chest x-ray is preferred. The medications, even the medications is given by Sage AI. So you can add any medication from here, or if you think this particular drug is not to be given, you can delete it from here. So once you see for the medications also, the frequency, the duration, the dose, everything, what type it is, if it's a syrup or injection or capsule tablet, everything will be mentioned in this patient treatment plan. And once this is done, you can copy this prescription and then just forward it on the WhatsApp of your patient. This is how simple now patient treatment plan is for doctors. So I have tried my best and explained you all the features of the Sage AI. Any comments or questions are mostly welcomed. And one more thing, I would kindly recommend all the faculties mentioned here, present here, and the viewers to download MediSage app and start using Sage AI so that we can get reviews from your end. So yeah, that's it from my end. Again, thank you, Shama ma'am, for this opportunity.
Okay, thank you, Neetu. So our next webinar will be on April 11th. Hopefully,
Sure.
we will discuss with our team and let you know details.
Sure.
Okay, thank you so much, everyone. Thanks for
Thank you
joining.
so much. Thanks for joining.
Thank you for the opportunity. Thank you, Dr. Anuradha. Thanks very much.
Thank you,
Thanks a lot.
Sushila ma'am, Jyoti Prakash sir, for giving your insights in
It's
this
my
lecture.
privilege.
Thank you,
Guntur
Anuradha.
is always there.
Thank you, Shamam.
Thank you, everyone. Nice
Thank
meeting
you.
you, sir.
Thank you, ma'am.
Bye-bye. Good night.
Bye.